We are going to look at a chest X-ray with features of pulmonary arterial hypertension and trying to find out the possible reason for the pulmonary arterial hypertension in this particular case. And also there are some mentioned methods of evaluation of pulmonary arterial hypertension and its consequences on the chest X-ray. This chest X-ray shows typical features of severe pulmonary arterial hypertension. You can see that there is some cardiomegaly with right atrial prominence, and main pulmonary artery segment is very much prominent. The left pulmonary artery also you can see here within the cardiac silhouette. This main shadow is the right pulmonary artery, descending pulmonary artery shadow. And you can see a couple of end-on vessels. End-on vessels, if you have plenty of them, there is one here also, an end-on vessel. That would indicate that the cause of pulmonary hypertension, pulmonary arterial hypertension, was probably previous left to right shunt. Then there are some fibrotic stents here also. These do not appear to be typical vascular markings, and they are most probably sequelae of previous respiratory infection, which are common in those with left-right shunt. But respiratory infection, frequent respiratory infection in infancy is more of a feature of post-tricuspid shunts like VSD and PDA rather than atrial septal defect. And why I am thinking of atrial septal defect in this case is cardiomegaly and prominence of the right atrial shadow are features of atrial septal defect with pulmonary hypertension and pre-existing large shunt. Because in VSD and PDA, right atrial enlargement is unlikely. And moreover, when severe pulmonary hypertension develops in VSD and PDA, the cardiac size, which would have been enlarged earlier, comes down. And it's a normal cardiac size that usually you expect in VSD and PDA Eisenmenger. And between VSD and PDA Eisenmengers, what you expect is if there is a prominent aortic shadow, that will be in favor of PDA. While if it is not there with normal cardiac size, that will be in favor of VSD. Then suprasystemic pulmonary arterial pressures are more likely in ASD than, because suprasystemic pulmonary arterial pressure almost never develops in VSD and PDA Eisenmengers. In VSD, there is a large VSD which equalizes the pressures in both ventricles so that right ventricular pressure can maximum go up to the level of the systemic level but not beyond. For the same reason, there is equalization when aorta and pulmonary artery has a large communication. In ASD, the main systemic circulation is isolated from the right ventricular side. That is why pulmonary pressures can go very high beyond systemic levels in ASD Eisenmenger. And these end-on views are also more likely in ASD because ASD patients take time to develop pulmonary hypertension as the flow is initiated later, and usually it is in the fourth decade or so that most of them develop severe pulmonary hypertension. Even though I have also seen some cases in second or third decades also ASD with pulmonary hypertension, but most often fourth decade or beyond, that's when they present with severe pulmonary hypertension. And there are some even who say that severe pulmonary hypertension and reversal, all those things are probably a manifestation of likelihood of an element of primary pulmonary hypertension in ASD, but that's all hypothesis. Practically, we would think that when you see these end-on views, we see that the pre-existing large left to right shunt is the cause for reactive severe pulmonary hypertension in ASD. So the cardinal features: prominent RPA, prominent PA, prominent LPA, right atrial enlargement, cardiomegaly, end on vessels, all indicating AST with severe pulmonary hypertension.